So being a clinician subspecialized in the field of movement disorders, I deal with patients with advanced Parkinson's disease for many, many years. So I'm quite aware that actually the face of Parkinson's disease in advanced stage changes very much. The quality of the patient decreases. There are also many non-motor symptoms accompanying the classical motor symptoms. So the patient really enters a new phase. What it was shown unequivocally with many trials and studies and research is that if we offer the patient continuous dopaminergic stimulation, we can really improve his quality of life. And while I did not argue for continuous dopaminergic stimulation to be introduced much earlier, my position at this pro and con meeting was that device-aided therapies should not be used much, much earlier. So why not? Well, first of all, at the moment, we've got 3 very successful continuous dopaminergic delivery device-aided therapies. One is Apomorphine pump, the other are Levodopa gel-based intraduodenal infusions, and the third one is deep brain stimulation. Common to all those 3 therapies is that actually they are very efficient, but they are very cumbersome and they are very complicated. They can be introduced with a very specialized, subspecialized, very knowledgeable expert team who has lots of experience in movement disorders, particularly in advanced Parkinson's disease. The other thing is that we can introduce them also only or basically when the carer is prepared to cooperate very much and when he's of great support to the patient. The other characteristic is that all 3 device-aided therapies are actually very invasive. They require either a hole in the tummy or a hole in your head, or at least penetrating your skin every morning with a needle. So not everybody really is prepared or is happy with these sort of treatments. Another important thing is that, as I said, they really need an expert team, not only an expert neurologist subspecialized in movement disorders, but they also need a complete PD Parkinson's disease team, including PD nurse, speech therapist, physiotherapist, psychologist, psychiatrist, neurosurgeon, gastroenterologist. So not every center really can afford or can organize himself to such a degree. Last but not least, probably one day the bill is coming to the hospital, and these bills for device-aided therapies usually are very, very high. Also, these therapies are also highly efficient and sort of revolution in neurology. They, of course, have adverse effects, side effects, as all the treatments, but of course more than just taking tablets or peroral therapy. So the side effects of these therapies can be quite significant, ranging from psychiatric to postural hypotension to some intracerebral incidents. And while patient in advanced Parkinson's disease, because they are so disabled and their quality of life is so low, they are quite they do sort of accept these level of side effects. But of course, if you are not advanced Parkinson's disease, if you are early or sort of mid-stage Parkinson's disease, then you don't necessarily accept these level of side effects. Then another problem is that the word advanced Parkinson's disease remains a bit unclear in neurology. There are several people try to define what is advanced Parkinson's disease. Several groups of people have tried it. Several famous, neurologists, the Delphi group, for example, in Europe, and many societies. Still, it is largely very individual. It depends on years, so in 8, 9, 10 years. So most of people would enter the advanced Parkinson's disease, but exactly the stage, when and how remains somehow elusive. Now, also, if we turn from advanced stage, look at our back mirror and go back to the early stage of Parkinson's disease, we actually don't know what the destiny of this patient will be. We know that Parkinson's disease is having many, many faces, that this patient who is sitting in front of us now with early Parkinson's disease may well have a very, very benign, very mild form of Parkinson's disease, and maybe 8-10 years from now, he will be perfectly satisfied only with oral medication. Some other patients, they progress very, very rapidly. Another thing is that, of course, sometimes early in the disease, we may well make mistake. I think there's no neurologist who in the firm believe that this patient is having idiopathic Parkinson's disease, was a bit surprised later on when he found out that maybe he's having multiple system atrophy, or maybe he's having essential tremor and similar. So we really need enough time to be sure that this is idiopathic Parkinson's disease, that it's complicated idiopathic Parkinson's disease. So these are basically the points which I was discussing in my CON stance. So I said, while I firmly believe that continuous dopaminergic stimulation should be used as early as possible in the disease, much before advanced stage, I'm not sure that device-aided therapies, as they are used in this moment, are really the best solution. And adding to that, I must say that the moment we are talking now, in research labs all over the world, they are discovering new drugs, new ways of delivery. We will have new forms of oral levodopa. We will have sublingual film of apomorphine. So we will have very, very soon, actually, we already have some of those forms. So the new, much less invasive methods are coming. Apart from that, not only the new methods of delivery are coming, but also a paradigmatic shift in treatment will arrive tomorrow or maybe the day after tomorrow. What I mean is the treatment which will not be based maybe on levodopa, on substitution therapy, but which will touch the prophylactic or neuroprotective or sort of modulation therapy, which will tackle the cause of why cells in substantia nigra are dying at this very moment. So my conclusion really was, yes, the concept of continuous dopaminergic delivery as soon as possible, much, much earlier than advanced disease, but with these invasive 3 device-aided therapies, I would not shift them much, much earlier than they are now, which is advanced Parkinson's disease. Let me tell you that one of the highly cited studies which proved that earlier use of device-aided therapy, in this case it was deep brain stimulation, improved quality of life, and but the study, early STIM, would just show that if instead of using it after 14 or 15 years of disease, you use them, I think 7.8 or 8 years in the disease, you improve quality of life. Yes, I quite agree. But, many people would say, okay, 8 years in Parkinson's disease, that's already in many patients advanced stage of Parkinson's disease, but not in all of them. And maybe if I conclude with all these points, is there are many neurologists, myself among them, who are treated maybe tens or even hundreds of patients in advanced stage of disease with levodopa-based gel infusions or apomorphine infusions or deep brain stimulation. But are we really prepared as physicians? Are our patients prepared? Are our carers prepared? Is our society, health systems prepared not to treat tens and hundreds of them in a center, but to treat thousands of them, because thousands of them are in sort of approaching or are in advanced stage of Parkinson's disease. So these would be my basic points. But I must say that, of course, I agreed with my noble opponent, Tobias, that we should be more courageous. We should start treating with continuous dopaminergic stimulation or delivery earlier, but with other sort of methods or improved methods. And if I may add, what is important is, for qualified decisions of what would be the best for the patient, what you badly need, are comparative studies. At the moment, we don't have any comparative studies comparing deep brain stimulation, all sorts of levodopa-based gels, infusions, apomorphine. So, what is the profile? Which is the best? What are the side effects? What is short and long-term outcome, or maybe dangers? Let me remind myself and our listeners that recently there was a very interesting article in Movement Disorders which showed that they compared Lewy-body diseases in patients with deep brain stimulation and on those who had not been on deep brain stimulation. And what came out is that patients who are on deep brain stimulation, they've got a higher burden of Lewy bodies. They didn't have less, or their nigral cells did not die, but they had higher burden of Lewy bodies. What does this mean? It means something. Maybe it's protective. Maybe it looks. Maybe it's good. Maybe it's bad. We just don't know. So what we badly need are studies, and then after studies will convince me, I may join to the outcry. Let's do it as early as possible.